Welcome to the NCT Data Science Seminar. It's a pleasure to have you all here today. We're especially pleased to welcome today's speaker, Professor Dr. Bernhard Kainz, and thank Evangelia Christodoulou for hosting today's event on behalf of Lena. Thank you for joining us. We are looking forward for an inspiring session. Eva, the stage is yours.
Thank you, Doreen. Good morning, everyone. It's our great pleasure to welcome Professor Bernhard Kainz to today's NCT Data Science Seminar. He holds academic positions at the Friedrich Alexander University from Erlangen, Nuremberg, and Imperial College London, where his research focuses on machine learning for medical image analysis, with emphasis on explainability, normative modeling, and real-time applications in healthcare. Also, he is involved in translating research to practice, advising Think Sono and co-founding Freya. Please correct me if I'm completely mispronouncing the names of the companies. And today he will be presenting a talk titled Beyond Supervised Learning, Exploring Novel Machine Learning Approaches for Robust Medical Image Analysis. Please join me in welcoming Professor Kainz. I'll now hand it over to you, and I'm really looking forward to your talk.
Yeah, thank you very much for the introduction. And indeed, I would like to motivate this middle part from your introduction a little bit, what normative learning is and why I think it's important for the kind of work we do. And as it happens, you also said I'm involved in a couple of startups. And so sometimes I also talk to non-academics there and very interesting people like venture capitalists. You know, these are VCs, people who invest money in early ventures and have very particular views. Of course, they are very interested in return of investment of their initial investment and expect a lot of return. But the climate changed in the last couple of years. So when we started with this 2016 around, with this translation, I mean, the money was relatively loose. So people were very excited about AI technology, very high expectations. This thing will solve all of the problems in the world. And if we don't invest now, then we'll miss the next Google, Apple, whatnot opportunity. But recently, the discussions with these people go more in the direction as shown here on the slide. The kind of sentiment shifted a bit towards, well, these AI technologies, they didn't live up to their promise, more or less. By the way, a promise we didn't really make. This promise was made for us. But it's kind of that. It's probably going the same avenue as VR, AR technology. I don't know how many of you have lived through the times of the early 2000s when this was the kind of AI of the time, the hype, where people were expecting, well, in a couple of years, everybody will be running around with VR and AR classes, and this will revolutionize everything. Well, it didn't. It's very important in certain areas, but it didn't. The same probably is happening right now in AI research and in the translation to the clinic, because there are lots of problems we did foresee, but did not address from the very beginning, of course. And some of these problems I'll try to motivate you today as well. We see this kind of decline in interest also in current investments, but I believe what this actually reflects is something very well known, especially in engineering, the Gardner hype cycle. So initially, we have some peak of inflated expectations. We are probably around 2015, 16 or so, very, very high expectations. Then we enter some draft of disillusionment because no, it's not the perfect solution. We are not kind of solving all of the problems. We are only solving some of them. And these some problems we can solve usually translate into very productive areas. And I also think machine learning is not a monolithic kind of technology that is somewhere on this hype cycle we found. I think we are at several stages here right now. For example, I think categorical machine learning, things we do since 12, 13 years now, and probably longer, since the 80s actually, this is really moving towards some applications that are really showing value and return of investment. Other areas like generative machine learning, probably they're still on the kind of hype area. And I believe newer other areas like what I try to motivate in this talk, normative learning, is probably somewhere here. But what's actually the problem? Why did we not find the solution 2012 when AlexNet was proposed, and all the image classification and all the kind of data classification was now becoming better than actually human performance. Why didn't we solve all of healthcare problems as well during this time and these last 10 years? Well, in effect, you know all the problem. Categorical machine learning can work very well if the categories are known and if the data characteristics are very well known. Digit classification or whatever classification where I have a set number of buckets where I want to sort my data in works very well. If classes are balanced, that is usually an advantage. Some usually less stated limitations of categorical machine learning as well. Of course, I need to be able to somehow define class boundaries. If this is not possible, then probably your problem is not suited for a categorical machine learning approach. And of course, also it must be possible to do some manual labeling. If you can't do it as a human, how do you expect a categorical machine learning system to solve the task for you? Maybe it's better categorizing certain breeds of dogs than you are, but with some textbook input, you would be able to label this. Now, the other problem is, especially in healthcare, and I'm very interested in high throughput population scale applications, is that actually statistics is something very poorly understood, or it's well understood, but we don't usually have a good intuition of what statistics is. So the real world out there, especially in my domains of health screening applications, usually is not very suitable for approaches like this, where class balance is key. Like here on the left is an example in an area where I'm very active. Antenatal ultrasound scans is basically the one diagnostic approach that probably all of us underwent as the very first contact with healthcare system when we were still babies inside our mother's bellies. So ultrasound screening, that's a very, very old technique now, 30, 40 years old, that's only purpose is to confirm if a baby is normal, and if not, to do either referral or to find specific problems with the growth of that baby with some developmental problems. But naturally, it's the kind of population is very healthy. If you do health screening, most of the patients you see, 95% plus of the patients you see, are not really patients. They are totally healthy human beings. And that's very true for a lot of our applications. So naturally, we cannot conform with the limitation, with the requirement of a categorical machine learning system to have balanced classes from which I can learn. Antenatal health screening, for example, has just a 5% abnormality rate. So most of the patients are very healthy. Then within all of these abnormalities, these are all of the abnormalities we can find, categorized or not. Within them, we have subcategories, which are even rarer, rare cardiac diseases, things like congenital heart disease. This is kind of 1%. And the reality is really that most of them, sometimes they are discovered, but most of them are in the current workflows around 50% detection rates. It depends really what it is. If it's very obvious, detection rate is very high. But things like congenital heart disease, for example, even the target in most healthcare systems is, okay, if you find 50% of them during the kind of current pathway, then we are happy. It's a bit of a postcode lottery. It depends where you are. It depends on the skills and experience of sonographers. It depends on the pathways, what the actual detection rates are. Can be as low as 20% or even 0, up to 80% if you're in a very specialized center and with very, very experienced people. On average, it's about 50%. Now, the other difficulty with statistics is that false positive rates and probabilities basically are a multiplicative factor in our environment, which means on the example of, for example, mammographies is another kind of prominent example for health screening. Half of the population undergoes this after the age of 50 to find breast cancer or not, because it's a very common disease in women post 50, relatively common. So you do this screening. And now every medical test has a specific sensitivity and specificity. That's very well known by all of you. But what this also means is that because there's a certain likelihood for false positives, a doctor, for example, would not apply simply every single medical test to you only to find if you have any sort of disease, because you will. There is a common saying in the clinic, which is, well, there is no healthy patient. There are just patients who are not diagnosed enough. You will find something. If you throw every test at every patient, you'll find something, most likely a false positive. And the issue with these false positives is really that they accumulate over time. If your false positive chance to have a false positive during your yearly screening is about 10%, so you have 90% accurate kind of detection algorithm or human, then this accumulates. If you do this 10 years in a row every year, then over this 10-year period, you will have a 50% chance for a false positive. Yes, there are procedures in place to avoid them. You will be referred to do more tests, probably a biopsy and whatnot, to really find if it's a false or a true positive. The issue is, in health screening, specificity is key. So we have a much more biased view on specificity, while we also want to have maximum sensitivity, of course. But specificity is much more important here than if you're in any other pathway that, for example, in a cancer staging pathway where you know already, well, all of your patients have cancer, I just need to find what type of cancer, then you're probably more balanced. In health screening, you're always imbalanced. So we are talking still here about this, but a huge problem as well is not everything is categorized. Most of the diseases and most of the anomalies are actually poorly classified, or probably the first time you see them. Prominent example, COVID, right? COVID showed up, was a new kind of disease, but any standard classifier, any categorical machine learning system would have most likely just put it in a pneumonia category. Because that's a big disadvantage of categorical machine learning systems. They have fixed buckets. If there is something new presented to the system, it will be categorized in one of these buckets, no matter what. And most often is the background class something healthy, so it will be missed. It will be missed. So my research is a lot about finding these unknowns as well. And we are working since a while on something I like to call normative representation learning. I made some corollary here. This is mainly about a variant of density estimation, out of distribution detection, open world problems in, for me, domains where specificity is really key. So we want to really confidently confirm at the very first that something conforms to a given standard. Some patient is, for example, healthy, or is the images are of good quality, so it conforms to standards. And on the other hand, to detect if it does not. We are not focusing here on immediately identifying what disease it could be and where to go. We are rather filtering patients based on conforming to a norm or not, and then going for more detailed tests. And in fact, the motivation comes from how healthcare currently works. Most of current healthcare works exactly like this, just in a more simplistic way than you might currently think about. Let me show you an example. This is an example from my own health record. This is just, the NHS is very good in kind of keeping records and providing them to the patients. This is just regular blood tests, and this is the monocyte count in my blood over time. And there are a few interesting observations you can make here. First of all, these bars. So this is a one-dimensional value. It's just one test result. But there are these bars that can be all the same. Sometimes, or for some values, depends on your age or other kind of conditionings. But all it is a percentile of compared to the overall population. This is the normal range. This is the range where this test result should be somewhere inside to not be flagged as abnormal. And as you can see, at some point in 2018, I had an infection before, so my monocyte count was very high. This triggered my doctor, more tests, was everything fine, turned out, but that's all that happened here. And reality in especially health screening or most of healthcare right now looks exactly like this. I take very complex information from a lot of tests probably and try to project them as good as I can on a one-dimensional score. On something one-dimensional I can put into a percentile chart to see, is this patient normal or not? And I'm very proud to also show you some very this is just from a beginning of the week. This is one of the startups, Freya, who is also doing this, where we do exactly this and support the current workflow and try to take very complex ultrasound imagery and automatically determine these metrics. Yeah, we are not doing more than determining these metrics and putting them into the current workflow, which is exactly based on this. Given the age of the baby, is this a normal range for this image-based metric or not? I'll just show you this clip for a minute or so. So this is just nice to see a lot of technology moving into the real practice. What they were referring to was a trial. We just ran a prospective trial with this kind of technologies. I can show you later a little bit more about it. But what you might also have seen is that at the end of the day, it's a projection on one-dimensional images. But if you look at our images, so this is my brain, this is my heart, this is my daughter, and this is my son. So I believe that there's much more information in the images themselves as would be possible to just project down from a single metric and to determine if the baby or the adult is healthy or not. And it takes a lot of experience actually just to have somebody who looks only at these images with and without measuring, to tell you that all of these images are perfectly normal. So that's a very, very, very difficult task, but it's not a categorical machine learning task. So there have been approaches explored in the past by us and by others, but most of them base around the kind of similar ideas. So what I have here on the slide is just what I've just discussed. We take some complex data, we collect a large database of patients, of other samples, people who are healthy or not, categorize them, for example, in healthy only, take our measurements and build a large database or a canonical model of all of this information where we can compare against. So in the simplest case, this is just a percentile chart. So I take some measurement, put this in the percentile chart, and then decide based on where on this chart this measurement is, if this is normal or not normal. Now, very obvious thing, which was tried a lot in the very early days, was, well, if I can build a representation model with which encodes my image or just the image directly or multimodal data or any kind of data I have, and put them in some latent space, make some assumption of this space, build a hypersphere around this, and then just estimate the density basically, and where a new sample would land, and this would work. So this works pretty well for data up to probably 6 to 7 dimensions. It's the standard method for anomaly detection in very low dimensional data, tabular data, for example, time series data. That's the go-to way. There are still some issues with distances and correlations in these methods, but they work. They don't work at all for really high dimensional images. I mean, we are talking here, image scale and multimodal data scale embeddings, which are way beyond 6 or 7 dimensions, something like this could handle. So people very early, Georg Langs was one of the first in Vienna, explored kind of embedding models, so generative models that take an input and reproduce this input through some information bottleneck. You're probably all familiar with these techniques, autoencoding techniques, where the idea is, well, if I present only one category to this encoding model and then present something which has an abnormality in it, then the model itself should not be able to reconstruct the features that make up this abnormality. And so the difference between my reconstructed image and my actual input image will give me a lot of clues where in the image something is not normal. Yeah, this also works to some degree. We are doing some research here. It very much depends on the quality of your reconstruction, because most of the time your signal will be hidden in the reconstruction noise. Until recently, these approaches produced very blurry images like standard autoencoders, pre-VAE times. So these were very blurry. So you would basically just discover that your reconstruction is not very good. Only recently, where we had diffusion models and so on, this was really becoming a kind of a method to reconstruct and measure something beyond the noise. Also some things that generalize well beyond kind of fully registered data sets or very, very clear data sets. So this works well through a residual map, is used a lot. I'll also show you a few examples about self-supervised learning, where we can just manipulate images, do data imputation to find this kind of abnormal areas directly in mainly images right now, but it works for text as well, where we find them directly. So density estimation methods would be something like deep SVDD. Every kind of autoencoding model has been used for these sort of anomaly detection methods, from GANs over VAEs, diffusion models. For this kind of classic approach, we would rather go back to segmentation and localization, find this area, take the measurement, and then put the measurement in your percentile chart. And we have been quite active in this kind of self-supervised imputation methods, which have a very basic idea I can quickly show you, but end up in kind of more complicated implementations. So what do I mean with this kind of representation models? Really, I think our overall aim, and this touches a lot of other areas, most people are currently interested in kind of dense representation model building, which is ideally a dense representation in a relatively low dimensional vector space, 1,000 dimensions probably. The catch here is that my representation should ideally be densely populated. So not a standard VAE representation space where most of the places are actually zero in this space. I want something where I can go from one sample to the next sample and get reasonable, plausible results on the way between these samples. The trajectory itself is still kind of a topic on its own. Euclidean usually breaks down in these high dimensional spaces, but we can also talk about these later. So if we have a dense representation model like this allows us to do a lot of things. All the kind of known anomalies, I can simply model like this. I can do counterfactual generation. I can change parameters and get an image in a what-if scenario. What if I would treat this patient differently? I can make really, really good kind of just images from very poor data. And I can do out-of-distribution detection, because anything with low support is probably out of distribution and goes beyond a simple hypersphere assumption as we had in deep SVDD. The dream in generative modeling, I think, and that's completely unsolved right now, is to probably learn the generating factors of the images. I think right now we just do data mapping, parameterized mapping of the data itself, but we don't really learn something that would understand and link to the generating factors of disease, of anatomy, of whatnot. If we could, that would really lead to real-world observations, and we could go beyond what our data tells us and simulate probably also other areas. Right now, we are somewhere probably in between here. We have this kind of sparse support with some ways to interpolate between the individual parts. Now, let me tell you a little bit, first before I do this, is all of dense representation modeling comes with a lot of overhead. So people are talking currently about foundation model building and whatnot. They're all dense representation models, but they usually take weeks to be established. And ideally, I don't want any huge labeling efforts for this. So some can be automatically labeled, some can be correlated, like images and reports and whatnot. But I don't want to have a huge labeling workforce here, just labeling every single sample. So this is what currently probably a third of the world's energy consumption goes in. ChatGPT is trained like this, our models, but still everybody trains sort of their own foundation model right now, and then always talks about what one could do with it. Ideally, and I must agree with some of the machine learning community who say, well, ideally, there aren't 100 foundation models, right? The heart foundation model, the brain foundation model, whatnot. No, there is one foundation model, one medical foundation model, one you can base anything on. Or there could be one radiology foundation model. Because if you would have that, this standardized representation, then specialization is relatively easy, either through labeling or to do DOD, density estimation, and so on. All of that can base on these representations. Has been tried in the past. Vector databases and so on are a common example. Is not at the standard where we would need it yet to reach, like in my case, the specificity needed. So some ideas around how do you now do this self-supervision. One thing we were very successful in is when we ask ourselves, well, what is actually between two scans? What is between my brain scan and your brain scan? We cannot just linearly interpolates these things. This makes just a mess in between. We want plausible brains in between. And so many years ago, we came up with this idea that actually we can just take a patch from your brain, put it in my brain, but we need to do this very carefully, because if I just take a patch, I generate at the boundaries of this patch a very, very strong training signal. So all I want to do is to get a patch plausibly integrated, and there are methods, computer vision methods and other methods we have used here, so that if you would only see the difference between the left side brain if I switch around between the slides, because it's so plausibly integrated. And that's something I can automate. And very surprising here is, okay, with that I can build a dense representation model that also covers data imputation, so all the bits and pieces that might be between people's brains or whatever, lungs and hearts and so on. So that works very well. What surprised us a lot is this also works very, very nicely as a direct out of distribution detector, because what I do here, I generate my own training signal. I can tell the model, look here at this area, I manipulated the image, find the manipulation. And I'll also show you in a few slides. Actually, this works surprisingly well, not only to find manipulations we have done, but it also is a perfect tool to find also manipulations nature did. Like a tumor, like some anomaly, like some scan artifacts. It's very sensitive actually to these, only trained by mixing samples and telling the model where, basically a segmentation model, where the manipulation took place. But we can mix this with all sorts of self-supervised learning methods. We can do the standard thing like diffusion models. We can just sample from noise, project into the diffuse into the actual data distribution, get new samples. We can, if we have prior knowledge what we are actually looking for, and as I don't know, people who work here in radiology might probably be familiar with what we are actually looking for in radiology. Most often is hyper intensities and hypo intensities. Well, if I know this, I can just simulate this, and our models are relatively robust against that. Looks very artificial. It will find hyper intensities later on. We can condition these things with text and all other meta information we have, lab results, history, patient histories, any sort of probably omics. We haven't tried yet, but I think it wouldn't be really a problem here. If we condition this, we can do the standard things the language model people have introduced, like just leave out, crop out a bit, and then try to reconstruct it. That's exactly the same as language models are trained. You have your entire text of all the internet or whatnot. You crop off a bit of that and ask the model to complete the sentence. That's the baseline training of all LLMs. You can do this with images as well. We can train the vision language tasks. So go from an image to, say, a report in our environment and describe the image. It's basically image captioning. We can go from the caption to the image. It used to be a little bit harder. Now with conditioning and diffusion models is also doable. But we have all of this data. We don't need any labeling here. We just need conditioning here to build these dense representations. And there are many methods now currently around to actually encode this, from transformers over VAE GANs, diffusion models, and so on. So we use all of them really to go back to the continuous dense representation of the generative factors. That, I think, is still an unsolved problem. We can explore a little bit disentanglement of the individual factors and see that things correlate, but really the kind of generating bit doesn't work, and I'll show you in a bit why. Yeah, that's what I said with localizing. So that's really surprising that this works out of the box as a really good kind of localizer. And we have used this for really a couple of works in the last couple of years. By now, we are with the localization as good as if you would train a supervised segmentation model, for example. So tumors and these things, they are found with almost equal dice score as if you would just train a unit on your manual labors. We have also found that you don't only need healthy patients for this. You can just exclude the disease and learn from the rest, because the rest of patients is usually functioning and shows healthy anatomy. Also, one of the reasons why the pure encoding decoding approach for this doesn't work so well, because most often your pathological features are also made up of features that also represent healthy anatomy. So we can mitigate this by just leaving out the anatomy and then training a self-supervised representation on the still healthy bits of the patient and find anomalies quite well. We did a lot with visual grounding and using basically grounding as a regularizer, where we describe bits and pieces of the image with language models. We did, in ultrasound especially, we did a lot of counterfactual analysis where you change parameters, you ask questions like, if I change this text or this treatment or this tokenization, how would that scan of that particular patient look in this case? And here you see changed ejection fraction, for example. So that's probably one of the few things that hasn't really extensively explored in explainable AI, for example, where we could use these things as setting boundaries for human interaction here. But also, of course, I can use this to just enrich data where I have a very imbalanced data set. Well, nobody says I couldn't just synthesize the missing class labels and class examples from the kind of less represented classes. This works very well. We did this in histopathology a lot, but this basically is used across the board to also demonstrate how good kind of dense representation embeddings are to enrich now new data sets. Still some troubles with this, which I'll also explain you later. If you have a representation of what's expected, I can also use this to heavily regularize inverse problems like sparse sampling in MRI to get to very plausible results given the data, the poor data I have acquired. And does it work for non-medical data? Yes, we have also shown this. This is also kind of a long-standing problem in the computer vision community. Think about manufacturing and automatically finding defects in the product you produce or whatnot. So it's also one of the probably leading methods right now to detect completely unknown defects and anomalies in computer vision. So thanks to your lab and David Zimmer, don't know if he's here today, David Zimmer organized this kind of challenge a couple of last years in MICAI, which we won a couple of times. And so thanks to that, we could also compare to other approaches out there. And at some point, Matt here also sat down and collected all of the approaches in this framework where you can basically directly combine these self-supervised, in this case, out of distribution detectors for localization, for image-wide classification, and so on, basically for out of distribution detection. And it's a nice plug-and-play framework to find and experiment with these OOD methods. Now, as I said, there is one problem still with our representations, which is usually they are not as good as your original data set. How does it show? If you would be able to model the generating factors, then throw away your original data set. At that point, if I synthesize data from such a model, all data I synthesize must be by definition better for any sort of downstream task. If I do a classifier, if I do a segmentation model, whatnot, anything I train just on the synthetic data should be better if I would really understand the data in my representation model. It's not the case. All of our experiments in this direction didn't show evidence for this. Let's put it that way. Usually what you observe is if you train exclusively on synthetic data, your downstream models will be something between 2 to 8% worse than if you would have trained on the original data. So what people do to this day is they usually combine the original data with the training data set, which comes with all the problems usually original data sets have, like data privacy issues and whatnot. But it also points us towards the underlying problem here. We are not really modeling yet the generative factors of that data, because if we would do so, we wouldn't need to combine. We could just go for this. So Hadrian here was working towards this direction. So with a lot of hard work around this for very specific data sets here, this is a kind of video generative model in cardiac ultrasound. With a lot of work, we got to this place where we said, okay, the long tail is now also covered. We can generate images and samples that will perform at least equally well on any downstream task than your original training data. That's where we just arrived, equally well. The ultimate goal, of course, would be to outperform the original training data and lead to real improvement here. Because if we could do this, there would be a very simple idea. This is also a long-standing idea in our field. You're all familiar with it. Usually your data is, well, privacy is an issue on your data, sharing, IP, whatnot. So ideally, you would like to just learn whatever you can from the data and then leave the data where it is, because sharing has a lot of bureaucratic overhead and it's painful. It's great that a lot of people do it, but I think it's unrealistic that we do this for every niche application. It's just too much work to really get on. So the idea would simply, well, why don't I train inside of the place in my walled garden of my clinic a model that learns the generative factors of that data, then synthesize with some privacy preserving measures, a large data set which is guaranteed to not contain any personal identifiable information, anything that's related to the patients, and then share this, and then pool all of this data, would solve all of the problems with differential privacy and federated learning and so on. So why not? Because of what I just said. Right now, it's not doable. Our synthetic data, first of all, okay, needs to be privacy preserving. That we have under control. So we can guarantee that the model is kind of secure, but also we can provide hard guarantees later on the data set that none of these images will identify any patient ever. But the bigger problem is consistently we observe that our data does not cover the entire distribution. We see gaps, usually in the long tails, usually in the rare areas, which we have just started to understand and to characterize. We are not really at the level of solving this yet. We have some vague ideas and have published things in this direction. So this year in CVPR, Misha did some kind of great new metric to actually evaluate your model, how well it covers diversity and the long tails, and then proposes a little bit of a mitigation strategy around diffusion models, how you can exploit this to make diffusion models that also cover your long tail, because you really observe this. And it's not only computer vision, of course. The computer vision community is mostly interested in nice images here. The diversity is probably secondary. Sometimes diversity for us is key, because we are not really interested in the images, right? We are interested in the downstream applications we can build from these images or data sets or whatever synthetic data samples we can use. We are interested in the kind of parameter workflow and not most often in the images themselves. So this pretty much distinguishes it. And I mean, you observe it yourself. If you use ChatGPT, the first few samples, I think you were not able to distinguish from real human writing. They're just perfect. Now, since you have used it 1,000 times, I'm pretty sure you're a good classifier finding evidence of ChatGPT writing is not only the kind of missing commas or whatnot, it's a specific style of writing. It's always the same. It's never diverse. So that's the same issue. It's the same issue. We're very good sampling somewhere close to the mean, which is already very rich. But we are never sampling in the long tails, which is a problem I think we need to address in the next couple of years. So I have a little bit of a task for you. This is generated versus real data. Those of you who think the left image, that's basically histopathology of the kidney. It's just tubuli. But those of you who think the left image is a real image, can you give me a thumbs up? And those of you who think the right image, so image B, is the real image, give me a heart. If you can put this into, you know how this works. You just react and then yes, perfect. Very nice. See a couple of hearts, couple of thumbs up, hearts, thumbs up. Very good. You're at the exact same level of performance as our 30-year experience pathologists. Single samples you cannot distinguish anymore. We are at that level since 2 years or so. All of kind of generative modeling is at this level. So this is the A is basically the right model. We can try this again. What do you think? A, thumbs up for A, real image, or heart for B, real image? Any guesses? Yeah, perfect. A heart. So B is real, you think? Anybody for A? Yes, so B is all right. You're wrong. A is real. Then this, probably we don't need to guess. You would expect that we have the same kind of 50-50 accuracy. We have also shown this kind of with experts that 50-50 is basically the guessing rate of what is real and what is not. This is already very old work. We did this in 21. So this is real, this is generated, and by now we are, of course, much better in this kind of multimodal things. I'll probably skip this. We can also model with deep representations the possible solutions if we use stochastic diffusion here, the stochastic models. they need to be regularized in a certain way. So if you're interested in this, we use some random dynamic systems here to regularize the diffusion process so that our output is always not only plausible but also correct. You can read this in Wei Tong's last Neurus paper, and we are also looking into similar mechanisms for language models, agentic language models, where correctness also needs to be distinguished from plausibility, because you might have also noticed when you use ChatGPT that sometimes output is very plausible, but still very wrong sometimes. It's the same problem we had always with segment classification, basically. Sometimes the models are very confident and very wrong. So here in this kind of system, we try to prevent this collusive equilibria between agents to have a kind of regularized discussion about what the right output could be here. Very important for healthcare. We must not forget standard uncertainty is very, very important, but it needs to be calibrated, because otherwise it doesn't generalize. So all of kind of uncertainty modeling revolves sort of around uncertainty calibration. So what we did here is we modeled basically from the input through the entire network image patches as Gaussians, which works very well and very robustly for calibrated uncertainty, also as a good kind of metric to decide about selective prediction, right? Selective prediction means that you allow the model to not make a prediction given a certain uncertainty. So if I expect the model to be 95% confident in what it does, and that needs to be calibrated, then and anything below it just says, well, I can't make a decision. We also use kind of Laplacian approximations recently to bring this into segmentation. This is a kind of fetal heart where these kind of approximations also allow us to do this sort of modeling, because all of that modeling is extremely expensive. I cannot simply determine in the backward pass the Hessian of my kind of model to get an idea of how things change, and so variability. I need to do tricks like Laplacian approximations to get to segmentations that give me an indicator, like here a normal fetal heart. You also already see here how terrible these images are actually. Normal fetal heart, very, very, very confident segmentation, very high uncertainty in an AVSD case, which basically has a hole here. And so the entire segmentation is a bit unsure, because that also goes over the video and shows how and integrates temporal information. Now, if you bring these things together, like uncertainty-based segmentation and everything we know about the statistics, then this is how current products look like. Like in the example I showed you earlier from the news clip, this is what we do here. We measure the uncertainty plus the measurements over time, a lot of time, and then rely on the law of large numbers and central limit theorem to get closer and closer to the real estimate. And this really works. This actually really, really works. If you anyway automatically acquire a lot of data, just accumulate them and be smart about how these are combined, because your central estimate will be extremely, extremely close to the real to the real measurement. So this currently went through a prospective trial, couple of sonographers blinded and prospectively scanning pregnant women. You have no idea how complicated it is to find pregnant women if you need to be embedded in a specialized clinic like we're here in Evelina. Very, very good results, accuracy top-notch, but also time saving. So we do the entire scans now in a couple of minutes in comparison to 40 minutes, simply by removing this requirement of the sonographers constantly having to stop, then measure, then find the spot again. You just scan and talk to the patient, and then everything else is automatically acquired. So overall, I think normative learning and kind of density estimation is not only important to make our models much more much better and much more robust. That's basically what we are all working on right now. We want to have machine learning algorithms that are super robust, reliable, and probably generalize across every single sample. I think we don't need to necessarily always generalize about all of the population, all of every single kind of subgroup of people who might show some oddities. No, I think what we actually would need to do is also do some quality control or model selection, right? You can use a normative model here and determine in the beginning of if that new sample is even suitable for the downstream model you would like to have, because your training distribution might be the normative distribution you've learned on. And so you can determine not only based on the clinical parameters like ethnicity, sex, gender, whatnot, but also on the kind of hidden image features, if these models are suitable for the algorithm you actually have determined to run on your patient. Super triage system. You can see every patient, but some patients might need more urgent human oversight, some less. You can do failure detection, and same idea. The expected output is your normative distribution. The non-expected ones will be sorted out and triaged. Everybody will be seen. So this is kind of also still unsolved. That's also something we are working on. Everybody of us has this idea that if we bring all of these things together, especially AI and humans, that we get much, much better. The only problem is humans have less bandwidth, but are super, super flexible in what they do. Now, there's a little bit of a catch to this because we haven't really found a good way to get this combination working. We did some experiments ourselves, and other people showed this in radiology and everywhere. The hypothesis doesn't really work out right now. Bringing just everything together makes things better, not necessarily. So we did these kind of tests. We assumed that if we bring everything together, everything will be better. And we tested. Well, the AI alone here, this is a very specific task, finds the AVSD in a lot of retrospective cases. In this case, we asked lots of experts, lots of sonographers. So the AI alone, the algorithm is somewhere at the 80s. If I just ask the experts, they outperform, in this specific case, the AI. We did some group-wise analysis here. So these are kind of very experienced people. These are less experienced people. So they are worse than the AI. And everything was like expected to this point. So then we presented the group with just the AI, the machine learning model output binary, has the condition or not, much better. And then we thought, okay, to get to our desired 99% kind of our AOC or whatnot, we just present more. But what happened was, unfortunately, the more you present, the more information you present, the less performant you'll get. We have some suspicions. We guess that it's a little bit of an automation, a negative automation bias. Like the more information the algorithm presents about its reasoning, the more credible it sort of gets, perhaps. So the more even the experts tend to believe what they see, despite having been told that the thing is only 80% accurate. So that remains to be tested. Bernhard has shown other kind of effects probably play a role. Depends a little bit on how they perceive the whole setup. Automation bias, again, is a big thing. So we don't know yet really how to combine humans and machines. Here's some references. So overall, I think we're really seeing some impact now, but more on the productive lane. Slow pace of healthcare. The prevailing issues still, I think, are this lack of triaging, this lack of out-of-distribution detection, this lack of failure detection, which is very common in other high-stakes scenarios, cars and planes and whatnot. We're not doing this yet in healthcare, not at this level. So I think these methods are very useful here. And we have the usual challenges, of course, how to bring this together with humans, how to do, you still need, even in these self-supervised methods, you need some labeling, how to do this effectively, because you need a test set, you need to compare against something at some point, even though you didn't use it during training. So these are all very big challenges. I think we still have quite a long way to go. And I rely on all of you to kind of making these things happen. And sometimes it's really nice to see things translating, even if it's then kind of aligned to the workflow like in Freya. So that's the team. Thanks a lot. And thanks a lot for the sponsors. Sorry, I went over time by 10 minutes, so I hope that's fine.